Bismillah ar-Rahman ar-Rahim. Welcome to ERA, Easy Radiology Approach. I am Dr. Muhammad Talat, Assistant Professor of Radiology, Gaillard University. Today we have a great surprise. We have Dr. Ismail Sayed Ismail. Dr. Ismail is not only my friend, he is my brother, really. I worked with him for many years, one of the professional consultant radiologists and one of the most famous teachers. So thanks, Dr. Ismail, for accepting our invitation to join us in our session. Inshallah, Dr. Ismail will take over in the second part of the session. I will start for all of you with the first part of the session. Okay, this patient is 48 years old, and he is coming to our department complaining of severe headache.
Okay. I have been provided with axial MRI images T2 sequence of a 40-year-old male patient who has presented with headache. So this is the topmost cut. And as
Yes.
I'm going, yes, as I'm scrolling through the images, I do not see any obvious loss of gray-white matter differentiation. There is no hydrocephalus. And I can see that the dural venous sinuses show preserved signal void.
Mm-hmm.
There is no crowding at the foramen of magnum. The cerebellopontine angles appear intact. The internal acoustic canals appear normal.
Okay.
Can we
Yeah. Okay. Can I show you the second sequence, please? Okay,
yes.
Go ahead.
So I've been provided with FLAIR sequence on which I can see that there are sulcal hyperintensities along both frontal lobes and also near the vertex in both parietal lobes. I am now looking at the gray-white matter junction at the corpus callosum to see if there is any abnormal signal intensity in terms of hyperintensity or signal void, which I don't see. Now I'm looking at the basal cisterns. So the presence of hyperintensities in the sulci on FLAIR sequence is concerning for either blood within the CSF spaces, which could be subarachnoid hemorrhage. And I would be concerned since the patient also presented with headache. So I would urgently inform the referring physician about my concern. And I would suggest further imaging evaluation with CTA or MRA if available to see if there is any aneurysmal rupture that has resulted in this hyperintensity. Otherwise, in the absence of trauma, there is no significant other cause such as a lesion which would result in the bleed.
Yeah, perfect. Candidate number one, you are perfect, really. As you said, here we have in the axial FLAIR, we have high signal intensity within the CSF in the frontal lobes, as you can see here, and here. Also, it extends into the Sylvian fissures also in the basal cistern of the brain here. So we have something abnormal in the CSF, as you said. And you told me one of the differential diagnoses that can match with the patient's complaint, severe headache. So our first possibility will be subarachnoid hemorrhage. And I think you did very well that we should inform the clinician immediately that we have a suspicion of severe or extensive subarachnoid hemorrhage. And CT angiography, yes, I agree with you, CT angiography or MR angiography. Really, the patient, I will give you the full history for this one. This patient, when he came to us to our department, the CT machine was not working at the time. So the clinician asked me to do MRI brain. I told him at the beginning why and blah blah blah. And I think later on we decided to do the MRI brain, and the patient was not cooperative at that time because of the severe headache. And when we did this MRI, we have these abnormalities, as you said. Can you give me any differential diagnosis for this pattern, abnormal high signal in the CSF, as you can see here in the FLAIR image?
Yes, sir. So it could either be abnormal CSF due to blood, or it could be post-infection. There could
Yeah,
be a high-density material or a purulent
yeah,
material which appears hyper-intense. Otherwise,
okay,
it could be a problem with the meninges themselves. For example, meningitis or leptomeningeal
okay.
carcinomatosis.
Very nice, very
And
nice.
also, if the patient is on very high oxygen in the ICU, it can also result in
Okay,
cervical hyperintensities.
very nice, very nice. So we have the most top three differential, as you said, either meningitis or bacterial infection. This one should be correlated with the clinical. So if you are in the exam or in our daily practice, you should ask the clinician, is a patient complaining of fever, high inflammatory markers, or something like this? May we think for meningitis, and may we recommend to do MR brain with contrast? And the second option also is leptomeningeal metastasis or leptomeningeal carcinomatosis. You are right. If the patient had any primary tumor or something like that. So those are the top differential diagnosis, as you said. And with correlation with the clinical, the patient proved to have severe or marked subarachnoid hemorrhage. And later on, conventional angiography was done and proved aneurysm really, but really I didn't have full report for this one, but this is a feedback that I received later on. Okay, thank you so much, candidate number one,
Thank
for
you,
this
sir.
great discussion really. Let's go to the next candidate. Can you leave the mouse, please? Yeah.
Yes, sir.
Okay, we need the next candidate, please. Okay, okay. Candidate number two, are you here?
Yes, السلام عليكم دكتور
Okay.
محمد.
وعليكم السلام وبركاته. Can you please send for me a request for remote control?
هات دكتور من الآيباد. ألو
أيوه. Yes.
دكتور ما نقدرش من الآيباد.
Okay, no problem. I will scroll for you. Okay, no problem. This patient is 27 years old, as you can see here, and this patient complained of right side hemiparesis. Okay.
I am presented with MRI cervical spine, surgical
Okay.
T2 image,
Yeah.
in which I can see there is cervical spine high signal intensity.
Okay.
Cervical cord, sorry. Cervical cord high signal intensity.
Yes, perfect. You are right.
في الميدل في central part.
Okay.
كان it's of long segment.
Okay.
وفيه برضو cervical spasm اللي هي loss of cervical lordosis, which
Okay.
means cervical muscle spasm. I will see the other برضو it's high signal intensity, long segment.
Okay. Is it long segment or two segments?
Two vertebral long.
Okay. Two segments, yeah. Are you right? Okay.
Yes.
Okay.
It's not a picture of
Okay.
MS,
So we have here,
MS
yeah. We have something here and something here. Okay. Is it central or paracentral or eccentric?
Can we see it in Excel?
In the axis. Okay. I will give you the axis. Okay. No problem.
It's peripheral.
What do you think?
It's peripheral.
Peripheral. Okay. So we have mainly two abnormal patches of altered signal intensity or patches of altered signal intensity involving the upper spinal cord opposite C3 and C4 vertebrae and it's located at the, which one is this one? Can you please help me in the
peripheral
description?
part.
Peripheral part, I think is the most suitable word here is dorsolateral corner. Okay, right dorsolateral corner, or at least right lateral aspect of the spinal cord. Okay, so we have this abnormal signal. It is located at an eccentric location to the spinal cord. Okay, involving the right side. What is your possible diagnosis?
اللي هي neuromyelitis optica.
Okay, what else?
الMS تقريبا more small.
Okay.
More short segment.
Okay. So you told me two main differential diagnoses, either MS, multiple sclerosis, or neuromyelitis optica. Okay. How can we differentiate?
لو كان نشوف البرين involvement.
Okay, very nice. Very
لو
nice.
كان فيه optic nerve involvement or
طيب, to finish also this one, I think we did for the patient surgical T1 with contrast and axial T1 with contrast. And if we compare the axial T1 post-contrast with the axial T1 pre-contrast, we don't have any significant contrast enhancement in the spinal cord. So, as you said, once we have any abnormal signal in the spinal cord, we will go directly to scan the brain. Very nice. Okay, let's see the brain. This is the brain.
I am presented with MRI brain flare axial view, in which I can see there is periventricular. كان فيه periventricular subcortical small foci of high signal intensity.
Okay.
Periventricular على lateral ventricle.
Okay. So we have abnormal patches at different locations. One of these locations is periventricular, as you can see here. Okay. Subcortical. Yeah, you are right. We have here subcortical or juxtacortical. Okay. So we have two different locations, as you can see here, multiple small patches, and one of these periventricular patches is perpendicular to the ventricular system. Yes, you are right. Okay. So, what's your opinion?
It's digital to see if this Dawson finger.
Dawson finger. Okay. I will give you this question. Okay.
Yes, it is.
As you can see here,
the corpus callosum and perpendicular على lateral ventricle.
Now, the corpus callosum itself, it's not involved. Okay. But we have multiple patches periventricular. Sometimes, or some of these patches are perpendicular to the ventricular system, as you can see here. Okay, so what's your final diagnosis here?
Multiple sclerosis.
Okay, multiple sclerosis. Can you give me the hand, please, to describe some points here? As we said, once we have any abnormal signal in the spinal cord, you should go directly to scan the brain, because 90% or 80 to 90% of the cases with multiple sclerosis, the brain should be involved. Okay, brain and cervical spine should be involved. It's very rare to have alone or isolated spinal cord affection. I think it is almost 10% of the case. So once we have some cases like this one, you should scan the brain. Okay, even if it is not requested by the clinician, please on the table ask the technician to take axial flare or at least axial T2 for the brain. Okay. The second point that I want to describe here, once we have any abnormal signal, neuromyelitis optica should be 3 segments affected at least. Okay, we have here 2 segments. Okay, and each segment about 1.5 vertebrae. Okay, maximum. Okay, it's not long segment. Neuromyelitis optica can take 3 segments, 4 segments, something like this. It's long, extensive segmental affection. The second point is MS, the standard or the classic MS. It will involve the dorsolateral aspect of the spinal cord. Okay, as you can see here. Look for this area. It is affected here in the dorsolateral aspect. Neuromyelitis optica mainly involving the central part of the spinal cord. Okay, okay, that's good. Second point that I want to highlight here that sometimes the plaques or the MS plaques can appear more prominent in the axial fossa spin echo, axial T2 fossa spin echo. Sometimes it is more obvious in the gradient echo. Sometimes it's more obvious in the axial T2 or axial T2 fossa spin echo. Okay, so it's not standard to see it in the gradient only or T2. Please take both of these sequences and compare or correlate these images with the sagittal brain. Okay.
Okay. Also, in my routine practice, I will see diffusion to see if it's active or not. Diffusion.
Okay. Okay. Very nice. Okay. I will give you some of these points. Yeah, as you said here, and you should correlate this one with the diffusion, searching for any activity. Really, we have one foci here, in this case here, yes, but it is not correlated with the dark signal in EDC, so it's not definite active plaques. Also, this one, it's not active plaques, it's T2 shyness effect, so it's not active. We don't have any active demyelinating plaques in this case, but this case was proved as MS. To diagnose MS, we have, can you please help me? How can we diagnose MS? Because MS or multiple sclerosis, we saw many cases of MS. How can we diagnose MS?
الماكلويد criteria إن هي عندها
McDonald's criteria. Okay, yeah, McDonald's. Okay, no problem. Okay. McDonald's criteria. How can we apply McDonald's criteria in this case?
إن هي periventricular small foci of high signal intensity involve subcortical.
We have two main categories or two main classification or two main points. We have either dissemination in space
and in time.
Yeah, and dissemination in time. Okay, how can we apply dissemination in space in this case?
اللي هي periventricular و
we have 5 regions. We have 5 locations for MS. Can you enumerate these 5 spaces, please?
Periventricular.
Okay. Periventricular, including corpus callosum and callosum septal interface. Okay. What else?
U fiber.
Juxtacortical or subcortical. Okay. What else? Infratentorial. Yes, infratentorial, including the cerebellum, middle cerebellar pedunculus, and the brainstem, and spinal cord. Okay, this is number 4. What else?
Optic nerve.
Optic nerve. Very, very nice. Perfect. Those are the 5 regions. McDonald's criteria. If we want to fulfill the dissemination in space, we should have 2 spaces out of these 5 spaces, and at least in every space we should have more than one lesion. Yeah, you are right. So in this case, we have periventricular and juxtacortical and spinal cord. So we have 3 regions. Okay. By the way, in any case of MS, please try to scan the optic nerve. At least take coronal T2 or coronal flare for the optic nerve to check the optic nerves. Okay, it's very important to include the 5th region of the MS. Also, a dissemination in time. What does it mean, dissemination in time?
اللي هي تقريبا في كل سكان نلقوا عدد enhanced gadolinium lesion increase number.
Dissemination. Okay, dissemination in time. That means that we have a proof that the patient has different attacks, or between these attacks there is an interval time between these attacks. How can we prove this one? If we have this scan, for example, we should review the previous scan to check if there is a new plaques or not. If we have a new plaques, this one fulfill dissemination time. If this scan, for example, this is background and we did or we will do follow up later on, and the new scan or new demyelinating plaque appear in this new scan, so we have a proof that we have something interval, a change in the number and location of the demyelinating plaques. Also, if we inject the patient IV contrast and we found some of the demyelinating plaques not active, not enhancing, and some of other plaques are enhancing. So we have some chronic plaques and some active plaques. So we have two different patterns of plaques. So this one can confirm that we have dissemination in time. This scan for this patient, we did this scan. This is the first scan for the patient, and we didn't have any previous scans. So this one is fulfilling dissemination in space, but it doesn't fulfill dissemination in time because this is the first scan, and we don't have mix between enhancing and non-enhancing plaques. So this one should be correlated clinically
with the cerebral
with the reflection,
spinal
and should make another follow-up because this one is suggestive for MS, highly suggestive for MS, but we need to make follow-up to confirm dissemination in time. Okay, that's good. I'm sorry that we spent a long time in this case, but to highlight some important points. Okay, thank you so much, Kent. نعم
ممكن سؤال؟
اتفضل.
هو الاكتف ليجنز احنا بنعرفها بالديفيوجن ولا بالكونتراست؟
هنقول كل الكلام ده، لا تقلق. We will say all of these points. How can we determine the activity of the demyelinating plaques? We have 2 points, either contrast enhancement or restricted diffusion. Why restricted diffusion? Because restricted diffusions, once we have any demyelinating plaques, it will be surrounded by cytotoxic edema that induce restricted diffusion. So we have 2 criteria of activity, radiological signs, either contrast enhancement, and we have different pattern of contrast enhancement. We will discuss this one later on. Also restricted diffusion. And out of the literature, I will tell you some secret from my experience. Mass effect. If the demyelinating plaque, or if you have MRI brain and the MRI machine couldn't take diffusion with image properly, or no diffusion with image was present at that time, and if the patient is not prepared to inject IV, search for any mass effect. If this demyelinating plaque causes any mass effect, this one can help you to determine the activity of the demyelinating. But according to the literature, we have 2 main criteria: contrast enhancement and restricted diffusion. Okay.
تمام.
اوكي.
بس سؤال تاني.
نعم. اوكي.
هو احنا في البرين سوبراتنتوريال ليجن بنبص عليها بالفلير
حلو قوي.
بنبص عليها تي 2 صح؟
انت احنا كل all of these points we will discuss this one later on in the tips of the session. But anyway, if we want to detect demyelinating plaques supratentorial, axial flare is the standard. If we want to detect demyelinating plaques in the posterior fossa, axial T2 is the standard, because some of the CSF pulsation in the posterior fossa can make some artifacts in the flare image. So flare, it's not the standard. It's not ideal. Axial T2, it's ideal for the posterior fossa. Axial flare, 3D axial flare, we will describe this one later on. It's very important to detect all the plaques. Okay? Okay, let's move to, let's move to the third case. Third case, this one, this one, third candidate. Are you here?
السلام عليكم ورحمة الله.
وعليكم السلام. How are you?
الحمد لله دكتور.
You want me to scroll or?
I can ask for control.
Okay, ask for remote control.
I will request remote control.
Yeah, okay. Go ahead. Okay. This patient came to me really complaining of headache also. Can you please check?
I will use the arrows by, okay.
Yeah, as you like. Okay.
Okay, this is a CT scan study of the brain, axial cut without IV contrast for a patient who is complaining of headache. I will scroll through different cuts before I start.
Muhammad, can you remove the annotation on the screen?
Okay, I'm sorry. Okay.
Okay. I will scroll to different cuts. I cannot see any areas of abnormal bleeding, whether intraaxial or extraaxial, preserved gray-white matter interface, normal size and configuration ventricular system, no mass effect.
Okay.
However, I can appreciate, I think there is areas of increased density, hyperdensity along the straight sinus and the superior sagittal sinus. Here, if you see my arrow.
Really, I don't agree with you regarding this point.
So
It's
it could
not,
be artifact.
yeah,
be artifact.
it's not dense. It's not dense. It's this one is the usual density for the straight sinus.
Yeah. Could be okay. Could be partial voluming.
Yeah. Okay.
However, I will continue scrolling. The areas of calcifications here near the Benier region.
Okay.
I will continue scrolling. I will continue. Maybe here also in the areas of sigmoid or transfer here also could be also I'm suspecting areas of increased density along
maybe not really.
Okay. Posterior fossa structures.
Okay.
I cannot see any crowding. I cannot see any specific vein here.
Very nice. Totally agree.
All in all, I couldn't see any significant finding. However, I will make another round.
Go down, please.
Okay. I will make another review.
Okay. Yeah, because can you review again the posterior fossa, the foramen magnum, and can you check the foramen magnum exactly?
Okay. I will go again to area.
The level of the foramen magnum again, please.
Okay. Here, I think in the right cerebellopontine angle.
Nothing. This is artifacts. Yes.
Okay.
Beam hardening artifacts. This one is.
It's beam hardening.
Okay.
Yeah.
Okay. Can you go more inferiorly, please?
Okay.
Go to the level of the foramen magnum.
Okay. Okay, I can see the areas of
I am doing this one to save your time, really. But in your routine practice, to pick up this abnormality, I took a long time. Okay, so.
I think maybe there is area of hypodensity here in the anterior, the medulla oblongata here. Okay.
No. All of these are artifacts. Yes.
Okay.
Can you go more, please, inferiorly to the level of the foramen magnum, please?
Okay.
Okay. Can you stop here? Can you see any abnormality, please?
Here, I think there's feeling defect here on the right side.
Yeah, very nice. Very nice. What can you see here? What is this structure?
This is a defect in the right internal jugular vein.
Very nice. Okay, it's not only defect. This hypodense area, is it surrounded by something abnormal?
ممكن تكون it's a long segment. It's extended.
Okay. I will help you. Just a minute. Give me the handle, please. Okay. If we zoom like this, okay. Look for the internal jugular vein here on the left side, and look for the internal jugular here on the right side. You will have something like filling defect, as you said here, but we have something abnormal here. This one is hyperdense. Can you see this one? If we go more superior, inferiorly, look for this hyperdense area inside the internal jugular vein. Look, even the sigmoid sinus here is hyperdense. So what's your suspicious?
thrombotic.
It's acute thrombose. really we requested to do MRI for this patient. I will give you the axial T2 to make you familiar by this abnormality in the conventional. I know that it's very easy to see this one in the MRV, but really this is MRI brain for the patient before treatment, and this is the MRI for the same patient after treatment. Look for the difference. Can you see the difference? Look for the internal jugular vein here in this area. It's distended, loss of signal point. This is the internal carotid artery. Look for this area. This is the internal jugular vein, patent. This is the internal carotid artery. Look for the difference between those segments. This one is occluded. This one, it's patent. This one before therapy, before anticoagulant. This is after anticoagulant.
So I think, Doctor, if Doctor.
Yeah, go ahead.
I think isn't the proximal segment of the sigmoid, I think I saw also some.
Yeah, you are right. This one also, maybe likely thrombosed. Really, we did MRV. This one is thrombosed also, the sigmoid sinus. We did MRV and we confirmed that all of these segments are occluded, and this one can explain the severe headache of the patient. And after treatment, all of these veins start to recanalize. Okay. So if you have something abnormal in any dural sinuses in the conventional MRI, please check in different planes, in different sequences. If you have a loss of signal void pattern in at least two different planes, okay, either for example sagittal and axial, or sagittal and coronal. So we have two different planes at least. This one is suspicious to have dural sinus thrombosis. Okay, thank you so much. Candidate number 3, it's a tough case really, but you did very well. Thank you so much. Okay. Any case of dural sinus thrombosis, by the way, you should check the surrounding structures. Maybe something related, frontal sinusitis, for example, complicated by dural sinus thrombosis, pre-sagittal sinus, mastoid air cells. You should check the mastoid air cells. If you have a case of severe mastoiditis, complicated by sigmoid dural sinus thrombosis or something like this. Also, you should comment on the complications. Do you have any venous infarction or not? At that time, we don't have any evidence of venous cerebral infarction. Okay, thank you so much. Can we go to the next candidate, please?
مع حضرتك يا دكتور.
ازاي حضرتك عامل ايه؟ Okay, if you want to scroll. Okay, go ahead.
I'm presented with axial cut CT scan with no contrast. بس تقريبا في lag. تمام. I will scroll. I can appreciate there is hyperdense material seen within the lateral ventricle with associated hydrocephalic changes and evidence of transcondymal permeation.
Yeah, very nice. Perfect.
There is also an area of hyperdense material likely to be active hemorrhage. Hyperacute hematoma or acute hematoma seen at the right. The left occipital region and temporal region also.
Okay.
There is also a hemorrhagic fossa also noted at the brain stem.
This one, what is this structure, please?
This is
brain stem or?
No, this is...
It's cerebral aqueduct.
Yes.
Aqueduct of Silvis, okay.
The hemorrhage extends also into the fourth ventricle.
Very nice, okay.
I cannot see any crowding of the posterior fossa.
Okay. So give me your final diagnosis, please.
Intraventricular hemorrhage with intraparenchymal hemorrhage.
Intraparenchymal, where is this intraparenchymal?
I think here, this area.
This one inside the trigone. Do you agree with me?
Yes.
Inside the trigone and occipital horns of the
I
left
think
lateral.
this is out of this area. I think it's intraparenchymal.
Okay, this one inside the posterior limb of the internal capsule. We have like petechial hemorrhagic focus inside the posterior limb of the internal capsule. Okay, totally agree. But this one is intraparenchymal. Yeah, okay. But do we have any other intraparenchymal hemorrhage in this case?
In this case, there is a midline shift, so I will check for the brainstem to exclude the possibility of direct hemorrhage. Or
I want to ask you another question, please, because you told me that there is hydrocephalic changes, and I agree with that point, and we have also retrograde CSF permeation in this area, and this one indicates that we have acute hydrocephalic changes. Okay, I agree totally with this point, but once we have any intraventricular hemorrhage, what should we do? We should search for the cause.
Yes, possibly.
Okay. Give me the cause.
I think the most common cause is rupture of aneurysm. Is there a history of trauma?
Not agree. History of what?
Trauma?
No.
Is there any like anticoagulation therapy?
No. Is this area intraventricular or intraparenchymal?
I think it's this is intra. I think it's intraventricular hemorrhage here.
Do you think this area is intraventricular? This area. This area is intraventricular, okay?
Yes.
But the red area, the red zone, it's not intraventricular. This one inside, which structure is this one?
It's a thalamus?
A thalamus, yes, you are right. It is displacing the third ventricle. Look for the third ventricle here. This is the third ventricle. This is the third ventricle. It is displaced to the right side. And this is the thalamus. Yes, you are right. This is the thalamus. We have hematoma inside the left thalamus. And this hematoma dissecting or perforating. I love these terms. Dissecting or perforating into the ventricular system. So this is the main hemorrhage. This is the main cause. This is the most common routine exam or routine case. Okay. Once we have thalamic hematoma or basal ganglia hematoma can extend or can perforate or can dissect inside the ventricular system. So this is the cause. Give me the underlying cause again. What can cause the thalamic hematoma?
Venous thrombosis, one of the causes of...
No, the most common. Give me the most common.
Hypertension?
Hypertension, yes, you are right. Hypertension, hypertensive bleed. Hypertension is the most common cause of bleeding inside the basal ganglia, okay? And it's very common to see intraventricular extension, as you can see here in this case. So the bleeding starts in the thalamus and extends into the ventricular system, not the reverse. Okay, remember this point. So we have mix between intraparenchymal and intraventricular hemorrhage, and we have also complication for that, hydrocephalic changes and CSF permeation. And we have also the hemorrhage is extending into the fourth ventricle. Give me 2 bad signs in this case, or 3 bad signs.
The midline shift.
Midline shift, okay, you are right.
And hydrocephalus.
Hydrocephalus, okay, very right, very nice. Okay, what else? The fourth ventricular extension of the intraventricular hemorrhage. Once we have intraventricular hemorrhage with fourth ventricular extension, this one is considered one of the bad signs. Okay, thank you so much. Can we go keep with me case of intraventricular hemorrhage with mild hydrographic changes as well, extending to the fourth ventricle and extending to these two structures. What are these structures here?
foramen Loschka.
Yeah, foramen Loschka. Yeah, you are right. So we have an extensive intraventricular hemorrhage. We don't have any significant intraparenchymal hemorrhage, as you can see here. It's not like the same case. But once we have intraventricular hemorrhage, we should search also for any subarachnoid hemorrhage. Okay, subarachnoid hemorrhage can lead to intraventricular hemorrhage by ventricular reflux. So once we have an isolated case of intraventricular hemorrhage, you should search for any other causes, not only basal ganglia and thalamus. Search for the subarachnoid hemorrhage. All of these structures, we don't have any subarachnoid hemorrhage really, and this case is considered as isolated case of intraventricular hemorrhage. What are the causes for isolated intraventricular hemorrhage? Help me.
I think hypertension is not one of the
Hypertension also, yes, you are right. Very nice. What else?
I thought hypertension is not a cause.
Hypertension is a cause. It's
okay.
a cause of isolated intraventricular extension from the thalamic hematoma, also aneurysms or AVMs. All of these tumors, all of these are causes of intraventricular hemorrhage. If we have isolated intraventricular hemorrhage, it may be hypertension, cerebral amyloid, very rare to be AVM or aneurysms. Okay.
حضرتك بتقول الاميلويد انجيوباثي صح؟
Yeah, amyloid angiopathy. It's considered one of the causes of the isolated intraventricular hemorrhage. It's not common, but it is considered one of the causes. Yeah, hypertension is more common to cause isolated intraventricular hemorrhage. Okay.
Okay.
Okay. Okay. Thank you so much. Can we go to the next candidate, please?
السلام عليكم.
وعليكم السلام ورحمة الله. كيف الحال؟
الحمد لله.
الحمد لله. This case really it's very strange for me. Okay. Can you scroll or you want me to scroll?
Yeah, you can scroll, please. I
will scroll for you. Okay, no problem.
Thank you.
Okay, this patient is 14 years old, and really, the patient came to the ER many times complaining of abnormal gait. Okay, and finally, they requested to do CT scan of the brain. And this is a CT scan of the brain for the patient.
Okay. Yeah, I have been provided with CT scan at the ultrat. I could see the differentiation between the white and gray matter.
Okay.
There is the shape of the fourth ventricle is of the midbrain and it looked like more elongated.
I think more or less normal. I don't have something abnormal in the configuration of the ventricular system.
Okay.
We have abnormal gait.
Yes. Normal. I think it should both like more affecting of the.
I will help you because yeah, I didn't see the abnormalities at that time, but once I convert the window to make like stroke window, may help you to detect any other abnormality.
There is hypodense area within the right frontal.
Yes. Okay.
Yes, it's looked more hyperdense than the other side. There is other area as well in the tridone, right tridone.
Okay. Can you see here also at the temporal region? Do you have any abnormality here at this area?
Minimal, yes. Posterior, the middle cerebral artery bilaterally is more dense.
No. It's not so dense. Okay. I'm talking about the white matter. Can you please focus on the white matter again? You picked up some abnormalities, as you said here. We have something abnormal in this area.
Yes, they are multiple. There is another one, the right basal ganglia as well.
Hypodense area, really, and also this area. for I assume this area. But the most obvious one really, because all of these are suspicious for me really, but there is something here. Can you see, please? Can you pick up any abnormality here in the white matter? Which side
In
is
both,
affected?
yeah, the both temporal lobe, there's dilated occipital loop as well, the dilated temporal loop,
No. We have something here.
and we have hypodensia within the
Yeah, we have
left
hypodense area
temporal.
in the white matter in the left side. Okay, really I did as you did exactly, because I have something suspicious, but I'm not sure. Is it one? Are these patches present or not? I'm not really satisfied by the exam. What should you do once you have something like this?
MRI.
Okay, really, we did this one. It's 1st of September. Really, in the same
MRI
day,
or CT
yeah, in the
angio
same
could
day, I
solve the
requested to
problem.
do MRI of the brain for the child.
Oh,
Yeah,
multiple
and
high,
yeah,
multiple signal within both,
yes,
white matter, periventricular, and in the temporal region, bilateral and subcortical as well.
Yes.
Is there diffusion? Is it restricted diffusion?
I will help you. Okay, but before going to the diffusion with MS, what's your idea? What's your diagnosis? What's your differential diagnosis?
In that age, I would suspect demyelinating disease.
Okay.
Or
correct.
Other presentation could be Tabzel, the one which
Okay.
having multiple infarction at young age. If it's this
okay,
one
but
is
okay, but the anterior temporal region, it's more or less free, and it's not common in the pediatric age group really. The peak of CADASIL between 20 and 40, and this young age, I'm talking about this young age, we have multiple, as you said, multiple widely scattered deep white matter patches of altered signal intensity having a periventricular and subcortical location, and some of these patches having perpendicular orientation to the ventricular system. Okay, is that correct? Do you agree?
yes.
Okay, what's your differential diagnosis?
My myelinating disease could be
Demyelinating disease.
ADEM.
ADEM. Very nice. Okay, it's very logic thinking. Okay, ADEM. Okay, ADEM is acute disseminating encephalomyelitis. Okay, what else?
Infection could be also a reason.
Infection, what type of infection?
Infection with this stitching part, he's not immunocompromised.
No.
Okay.
We have two top differential, ADEM, and what else? These patches are perpendicular to the ventricular system. MS. Are you sure, ya Dr. Talat? MS can cause neurological deficit in a case of 14 years?
No.
Is that logic? Is that
no.
logic? It's logic.
No, it's more, it's more
No,
female.
it's logic. It's logic. We have an adult onset of MS. Okay? Adult onset of MS can affect pediatric age group. Okay? So we have two top differential, ADEM and pediatric onset of MS. Okay? Really, we have different points to differentiate, but I will help you. How can we differentiate between both of these entities?
I think ADEM have a history of vaccination or recent infection would be.
Very nice. Yeah, vaccination or previous recent immunization within 2 or 4 weeks before the insult. Okay. Really, I discussed with the father of this child, and he ignored or he didn't give me any data about all of these issues. There was no illness, no immunization history, nothing. What else?
Laboratory finding, although clonal antibody in MS will be positive if we
Okay,
search for
I'm talking
laboratory
about, I'm
findings.
talking radiologically. How can we differentiate?
Radiologically, MS should affect more the optic nerve, and it should be like accompanied with optic nerve
we
affection.
mentioned before the 5 regions. Okay, as you said, periventricular, subcortical, brainstem, and we have brainstem affection here, middle cerebral peduncles. We have
spinal cord and
those locations are matching more with MS. Is that correct? But we have something more. I didn't say MS involves the basal ganglia. Is that correct?
Yes.
I didn't mention that. Adam, it's common to involve the basal ganglia or not?
Yes,
or gray
it's
matter. Yes,
yeah.
it's more common. Once we have gray matter affection or basal ganglia affection, Adam, not MS. Okay.
Yeah,
what else?
Point.
This one point. Okay. Another point. The age group, you are right. MS, the child or the pediatric age group, it's not common, but it should be considered. Adam, it's more common in the pediatric age group. Adam is monophasic, not polyphasic. Monophasic means that the patient is complaining of one attack, not recurrent attacks. Okay. And when I discussed with the father of this child, I discovered that the abnormal gait happened many times before. One attack and another attack. And the second attack was severe more than the first attack. So it's polyphasic history. It's not monophasic. Okay. The patient came to the ER many times before. So it's polyphasic. So it's not Adam. Adam, it's not. And for me, it's not monophasic. The case is polyphasic. So we should think again for MS, especially we have these patches perpendicular to the ventricular system. What else? We have 1 point more.
To be sure that it is MS.
Yes. Really, I put both of these entities, but really I put MS before Adam. Adam here, it's a very remote possibility, and this case, by the way, proved to be pediatric onset MS. But we have here, we have a very important sign to differentiate. Look for the T1 here. Is it low signal or high signal? Look for this one.
Low signal.
Low signal. Look for this one. All of these patches, most of these patches, low signal in the T1. Black holes. Black holes will not present in Adam. Black holes are very specific for MS. Okay, so we have different points that can.
So Adam in T1 will be iso-intense?
Iso-intense, indistinct. Yes, you're right. Okay. Really, I will give you small tips. By the end of the session, I hope the time will be suitable. But this case was proved to be MS, and really we did diffusion for the case. And let's review the diffusion. Look for these areas. What do you think?
We have not restricted.
Some of them not restricted, and here it's restricted.
Yes, this one is restricted.
So we have some of these patches not restricted. This one is not restricted, but others patches are restricted. Look for here for the bones. It's slightly restricted. So yeah, we have some patches restricted, some patches are not restricted. So some patches are active demyelinating plaques and others are not active. So we have again dissemination time. We are fulfilling both criteria: dissemination in space, dissemination in time. And this case, by the way, we are following this case now for 2 years. And every time we have some new plaques, active plaques, non-active plaques. Okay. So it is a tough case, but really, thank you so much, because really you did as I did before. It's very strange for me, so I did my effort, and was complaining of left side weakness. You can scroll or you can send for me remote control. Okay, I will scroll for you. Okay, just a minute. Okay, no problem.
I am presenting MRI T2 sequence. I can see of the brain axial view. I can see there is a hyper intense signal, hyper intense focal lesion in the frontotemporal region. The region is showing surrounded vasogenic edema. Lesion doesn't have a mass effect, significant mass effect on the surrounding brain tissue. There is no midline shift. There is no obvious like hemorrhagic sequelae. In my opinion, there is other lesions are seen in the other side. They has similar hyper intensity signals seen in the other side, multiple. So in my routine practice, I will review this lesion in contrast study and the T1 study. Also, diffusion weighted image to assess. This is diffusion weighted image. The lesion has peripheral diffusion restriction signal.
Very nice.
So this is which give peripheral diffusion weighted image could be the abscess and the glioblastoma multiformes as well. I will correlate with patient history of patient history of constitutional symptoms like fever.
No fever, no raised inflammatory markers.
Also, this is I want to see this lesion in contrast study as well.
I will ask you a direct question, please. If this one is an abscess, is it ideal? Is it standard or is it keeping with abscess in this?
No, actually, like peripherally
yes, it's peripherally.
Is not
peripheral diffusion restriction. Yes, you are right. If it is abscess,
Yes.
So again, if it is abscess, the restriction will be not only in the peripheral zone, but in the center as well.
Right. So this is peripherally enhancing lesion with the restrictive in this this is post contrast study. I can see peripheral enhancing of the peripheral enhancement of the lesion. Now the lesion could be either either glioblastoma multiformes or high grading glioma. Metastasis if the patient is mid-age or late age. Also could be also inflammatory like the MS and ADEM. But the other
what type of demyelinating disease?
This will be MS Tumefactive type, multiple sclerosis.
Tumefactive MS,
or fulminant
what else?
This ADEM, if the patient has history of previous viral or post vaccination.
This patient is around 50.
So
I think it's difficult to be. We are thinking maybe Tumefactive MS, maybe glioma, high grade glioma,
maybe
with necrotic core, maybe metastasis. What else?
Maybe metastasis. It's less likely to be abscess as there is no restriction. All could be if the patient is immunocompromised. Could be also a lymphoma. In immunocompromised can cause ring enhancing lesion.
Very nice. You are perfect. So the top 3 differential diagnosis in this case, maybe Tumefactive MS, maybe high-grade glioma or metastasis, maybe lymphoma. Lymphoma in a routine case or the standard in lymphoma is a solid nodular enhancement. But in immunocompromised, as you said, sometimes it will take peripherally or peripheral contrast uptake. So how can we differentiate? We have these 3 differential diagnosis?
Differentiation between these could be spectroscopy can play a role on
Before
the
spectroscopy,
translation
I'm
between
talking
them.
here in this
Also, between glioma and lymphoma in this case, diffusion both will be restricted. MSF is active.
What type of contrast enhancement here in this case?
Yeah, what type of contrast enhancement? This is ring enhancement.
It's ring enhancement, but sometimes here, as you
ring.
can see,
it's open ring.
Sometimes it is less obvious here, so it can be open ring enhancement. Okay.
Open ring enhancement, so it is MS.
More likely Tumefactive MS. Okay, but sometimes remember this one. Sometimes high grade glioma can give us this pattern also. Okay. Open ring enhancement of the Tumefactive MS. It is opened towards the side of the cortex. Okay, but this case. Open ring enhancement, one of the patterns that can suggest Tumefactive MS. But in this case, also we have another point. We have multiple white matter patches. Of all the MS. Yeah, this is Tumefactive MS on background. So the key points here is the multiple deep white matter patches. Okay, so this is a case of Tumefactive MS. And and this one after treatment by many years cystic encephalomalacia for this area. Okay, so really you did very, very well, and you gave me a very good differential diagnosis for this case. By the way, we have another point to differentiate between glioma and Tumefactive MS: perfusion, MRI perfusion. If if we have cerebral blood volume reduced or hypoperfused, this one is with MS or Tumefactive MS. If it is hyperperfused, this one with glioma. Also, MR spectroscopy can help you. As you said, MR spectroscopy, both of them will show elevated choline peaks, but Tumefactive MS can reduce the N-acetyl aspartate for a little bit, but glioma will make much reduction of the N-acetyl aspartate. Okay, so those are the points that can we differentiate. Okay, thank you so much. Can we go to the next candidate, please? Candidate number 12. Candidate number 12. I think this case, are you present, candidate number 12? We are sorry that we missed you, candidate number 12, because of the time. I know that we extended our session for more than 2 hours now. Anyway, this case, I wanted to show it to you. This one is axial T1. We have something here, mass lesion or space occupying lesion at the left posterior parietal loop, and look for the contrast enhancement. It's complete ring, thick and irregular contrast enhancement surrounded by vasogenic brain edema. Look for the mass effect here. Too much mass effect, too much edema. It's not like the previous case. The previous case, as you said before, it is surrounded by mild edema, mild mass effect in spite of large volume of the mass. So this case is aggressive mass. This one proved to be glioma, glioblastoma, high-grade glioma with necrotic core. Okay, so the pattern of contrast enhancement is different. The edema and mass effect, it's more severe. And as we said together, that MR perfusion can help you. Do we have candidate number 1? Can we repeat again our candidates? Candidate number 1 or 2? Is there anyone?
I'm available.
Okay, I have 2 more cases. Okay, so candidate number 1, are you present?
Yes. Okay. I'm just changing my notes.
Okay, candidate number 1. This child is complaining of altered mental status.
Okay, so you will scroll?
Yeah, I will, if you want to scroll, okay, no problem. I will scroll for you.
Yes, sir.
To save your time, okay?
Yes, sir. So I've been provided with Excel. flare sequence, T2-edit sequence of MRI brain of a young child who is presented with altered mental status. So on the first inspection, I can see that there are multiple areas of abnormal signal intensity, hyperintense on T2-edit sequence noted in gray-white matter junction and also in the central gray matter, including the chordate heads in the internal capsule and the ganglionic region.
Very nice.
Bilaterally.
Okay.
Also, I can see that there was some abnormal signal noted in the brain stem in the posterior aspect of the pons and the midbrain. So there is no significant surrounding mass effect or edema, and there is no midline shift. No, the ventricular walls appear normal, smooth, and there is no evidence of low signal intensity in any of these lesions. So in a young patient, I would be thinking of either a demyelinating disease first of all, if the patient has recent viral infection or any evidence of vaccination. So this could represent acute demyelinating encephalomyelitis. This could
Okay.
also be secondary to some viral infection otherwise, such as dengue. And otherwise, less likely possibility of MOGAD, myelin oligodendrocyte glycoprotein disease could also be
Okay.
there.
Very nice. Okay.
Yes, so I would like to look at the optic nerves again, if there is any involvement of the high signal intensity within the optic nerves.
I think the optic nerves
So
are free.
yes, so the optic nerves are free. So if there is preceding viral illness and there is convincing history, so
we have when we checked with the mother of the baby, we found that the patient or the baby suffered from sore throat and headache 1 week ago, something like this, according to the history that is provided here in this case. So I agree with you that the first possibility here is ADEM, acute disseminating encephalomyelitis. We have multiple white matter patchy areas beside the basal ganglia and thalami. Here, once we have thalami, it's not mandatory to see thalamic or basal ganglia affection in any case of ADEM, but once we see this one, we should put we should put ADEM and remove MS from your differential diagnosis, because MS will not affect the basal ganglia and thalami. Okay, so well done. It's a case of ADEM, acute disseminating encephalomyelitis, and it's important also to check that. This another case of MS. This one is typical case of MS, periventricular, perpendicular to the ventricular system, Dawson fingers, as we see here in the sagittal flare. Do you have any explanation why Dawson fingers is perpendicular for the ventricular system? Do you know why?
Because there is perivenular demyelination, so the veins are oriented in this way.
Very, very, very nice. Again, these plaques are perpendicular in orientation because the medullary veins. This plaque is around the medullary veins. Okay, the medullary veins going horizontally, perpendicular to the ventricular system, and these plaques are surrounding these venules, these medullary venules. So this is the orientation for the medullary venules. Can I give you another point here? Can you see here in this sagittal flare? Can you see any signs for MS?
On the sagittal, I can see that there is a hyperintense signal on the undersurface of corpus callosum.
Yes, very nice. Do you know the name of this sign?
These are, I don't exactly remember. Garland sign?
No. This one is dot dash
dot
sign.
and dash, okay.
Yeah, subcallosal dot dash sign. This is, look for the plaques starts from the undersurface of the corpus callosum and going to the callosociptal spaces. Yeah, this is the classic pattern of MS. Also, the MS, it's very important to see the MS and characteristic to see the MS in the brainstem is the middle cerebral peduncles and the brainstem. Very important to localize all of these points. And don't forget the periventricular also around the fourth ventricle. Okay. Yes. As we said, the activity of MS can be either diffusion restriction or contrast enhancement. And in the contrast enhancement, we have different patterns. Sometimes ring, sometimes linear, sometimes incomplete ring, sometimes nodular. All of these patterns of contrast enhancement. Okay. I would like also to highlight some important points because of the time. This is a case of pediatric onset of MS, but I would like to look for this one. What is this sequence? Do you know?
The proton density? No.
No.
Susceptibility, right?
Susceptibility, yes. This is susceptibility, yes.
Yes.
Susceptibility weighted image. Look for the venule
This is a
inside.
central vein sign, which is low
Yeah,
signal
central
density.
vein sign. Very,
Yes.
very nice. Perfect. This is central vein sign. This is a medullary veins going inside the plaques. This is highly, highly specific for MS. Okay, so it's important to see here. Look inside the plaques. The medullary veins going inside. This is central vein sign. Okay. We have also another sign to end these signs. Look for the axial flare. Look for the plaque itself. It's very small. Okay. Look for the axial susceptibility. It's very large. Why? Because the rim is hemosiderin. Yeah, paramagnetic rim sign. That means that we have hemosiderin rim surrounding the plaque, displaying low signal intensity in the susceptibility weight image. Okay. So in my session today, we reviewed extraaxial flare hyperintensity as a subarachnoid hemorrhage, meningitis, leptomeningeal disease, leptomeningeal metastasis. Sometimes acute stroke vascular causes can cause slow arterial flow. Protocol for multiple sclerosis, flare, image, axial and sagittal planes. You can take 3D volumetric scan or isotropic scan and convert, for example, if you take the flare in the axial plane, you can convert this one to make sagittal or coronal planes. T2 axial to do 2D or 3D. T1, 3D inversion recovery, gradient echo sequences, diffusion with image axial, post-contrast axial and corona. It's very important. And sometimes if the patient complaining of any visual disturbance, please complete your study by taking either coronal T2 or coronal flare for the orbit. Okay. McDonald's criteria, as we said, we have dissemination in space, periventricular lesion, periventricular location, cortical, cortical, infratentorial, spinal cord, and optic nerves. According to this criteria, we should have at least two locations out of these 5 locations. Okay, dissemination time, as we described, if we have a baseline MRI, and we should compare this one with the previous scan if we have a new demyelinating plaque, or if this MRI scan is a base and later on we found a new plaque, this one is considered as dissemination time. Also, if we have in the same study mix between enhancing and non-enhancing demyelinating plaques, so this one is dissemination time or new clinical attack. If we have dissemination time, dissemination in space, this one is diagnostic for multiple sclerosis. Pattern of contrast enhancement, either ring enhancement, open arc, nodular, linear, and sometimes mixed between all of these. Activity of the demyelinating plaques, either contrast enhancement or restricted diffusion because of the rim of cytotoxic brain edema. The important signs of MS, as we described, T1 black hole, Dawson finger, ependymal Dosh, that sign, central vein sign, paramagnetic rim sign, open ring signs. All of these signs are very specific for MS. Correlation with disability. Sometimes you can check or you can predict the prognosis of the patient. Is there any high disability or not? Once we have black holes in T1, this one can be correlated with high disability of the patient. Volumetric assessment, sometimes in new researches, we can measure the volume of the whole brain, the volume of gray-white matter alone, and demyelinating plaques. And the most specific one is the gray matter atrophic changes according to the last researches. Paramagnetic iron lesions or a dark rim on SWI, this one is considered also a bad sign or accompanied with high disability of the patient. How can we differentiate between multiple sclerosis and ADEM? We describe this one. Multiple sclerosis multiphasic, ADEM monophasic. The peak instance is very important. Involvement of the gray matter, if it is involved, ADEM is suggested. If it's paired to multiple sclerosis. Callous septal interface, it's specific for MS, not specific for ADEM. Dawson finger is specific for MS also. Black holes, it's very important to be in the multiple sclerosis. Spinal cord affection, it's more common in multiple sclerosis. Optic neuritis, it's more common with multiple sclerosis. we have different variants of ADEM. One of the most important variants of ADEM is multiphasic disseminated encephalomyelitis. So ADEM can be multiphasic if we have this pattern. It's very rare, but we should mention in our session. Acute hemorrhagic leukoencephalitis, it's another entity from ADEM, and this one is considered as a bad prognosis because it's a hemorrhagic component. Last slice in our session, how can we differentiate between ADEM and MS in pediatric age group? Once we have a case of multiple white matter lesions, and this one is the first imaging study for the patient, we should have 2 out of 3. This one is called colon MS ADEM criteria. We should have 2 out of 3 criteria. If it is present, this one should be diagnostic for multiple sclerosis. If we have 2 periventricular lesions, presence of black holes, absence of diffuse bilateral lesion pattern. In our cases that we demonstrated before, we have 2 periventricular lesions and presence of black holes, so we suggest MS rather than M. Okay, I hope you enjoyed our session, and we are sorry.
تمام. السلام عليكم ورحمة الله وبركاته. How are you, my friends? I hope all of you are fine, inshallah. Inshallah, in the next few minutes or maximum hour, I'll talk about common lesions in the posterior fossa, exam-wise. يعني one case for discussion, then a differential diagnosis. Okay. The next candidate, number 6, I think.
Yes, sir.
How are you, my friend?
I'm fine, thank you. How are you, sir?
Alhamdulillah, alhamdulillah. Joining any near exam?
Yes, sir. Appearing in the March exam.
Whoa, March exam, so ask for control.
Oh, yes, sir. I have requested.
Okay, you have the control. Child 6 years old with headache, projectile vomiting.
So I've been presented. Sorry, I'm unable to scroll.
Yes, you are.
Yeah. So I've been provided with the T2-weighted axial MR slices of a 6-year-old child presented with projectile vomiting. The first abnormality which I can see is that the patient is having hydrocephalus. All the ventricular chain is dilated. So I'm going to the topmost crust and then I'll go back. I'm going back, and ventricular chain is dilated. The gray-white matter differentiation is intact in the cerebrum. And
is it slow?
Yes, it is slow. It is very
okay, no
laggy.
problem. I will take the control. Yes. Okay,
yes,
no
sure,
problem.
please.
Okay.
So there is an abnormal signal intensity mass lesion involving the central part of the cerebellum with which is causing compression of the fourth ventricle, which is causing all this hydrocephalus. This abnormal intensity mass is relatively hyperintense.
Okay.
So this is a mass involving the central region of the cerebellum. Can I have the sagittal view so that I can see whether it's
okay,
like
my routine
arising from
practice,
the...
I will check other sequences. Okay, I'll give you sagittal as you asked.
Okay, sagittal, yes, this mass is appear to be arising from the floor of the fourth ventricle and appear to be extending inferiorly through the foramina. So as like this mass is extending to the foramina, most likely
I'll give you the next sequence, which is
the post-contrast images. This mass is showing a post-contrast enhancement, and so most likely the top differential is ependymoma, which is extending through the foramen of Luschka and going into the foramen, like
good,
the
good,
foramen
good.
magnum.
So a midline posterior fossa lesion centered upon the fourth ventricle or the cerebellar vermis. You said ependymoma. Other differential could be
Other differential can be medulloblastoma.
yes. Why I write medulloblastoma as number 1 here? But you said maybe some foraminal extension. This is toward ependymoma. And at
Yes.
the floor, not the roof. This is also for ependymoma. Why I write medulloblastoma number 1?
Because it is more solid appearing, no cystic component.
Age group, you remember, even if I
Oh, yes.
didn't tell you the age, you see, a young child, okay?
Young child, yes.
And what about sequences? You saw all sequences? There is a very important sequence to differentiate between both.
The diffusion weighted images, because the
Yes.
medulloblastoma will be showing diffusion restriction because it is hypercellular.
Excellent, excellent. Very important, very important. Okay, this is very common in medulloblastoma, unusual for ependymoma. Okay, so 2 points
Yes.
towards medulloblastoma, the age group and restriction.
And the diffusion restriction.
And the
So
diffusion
I would request
You finalized the case.
So most likely medulloblastoma, as medulloblastoma is prone to have drop metastasis. So I would request
Excellent.
MRI of the spine as well to look for any drop metastasis.
Excellent to recommend imaging of the whole neural axis. But what about this study? What is this? What is this?
Yes, this is like increased enhancement of the basal meninges as well.
Yes, yes.
So
Good.
Most likely this is like drop metastasis or like
Excellent, my
CSF
friend.
seeding of the metastasis of
Yes,
these
it can affect the meninges. It can affect also the subependymal layer. It can cause subependymal metastasis or CSF seedling or along the spine. Very good, my friend. So can you finalize this case?
So based on all these images, the most likely diagnosis is medulloblastoma with the metastasis to the meninges as well.
Good.
So
I'm waiting for finalization. You said the diagnosis. What's next? March
what
candidate.
next? So I would advise the urgent neurosurgical MDT referral and the imaging of the spine as well to look for the drop metastasis.
Good. Very good, my friend. So it's a neurosurgical emergency. Remember, we have 3 neurosurgical emergencies, all with letter H.
Hydrocephalus, hemorrhage,
in T1 or T2, whatever, and gradient, of course, and
herniation.
Excellent. No tonsillar herniation. Very good, my friend. Very good, my friend. Okay. So this is a case of metastasizing medulloblastoma. Excellent, my friend. This is another, I think this one. Yes. This image from another case, but post-operative, as you see, a leptomeningeal metastasis all over the image, the brain, and also along the neural axis. You see, oh, It's nodular, whatever, or sugar coating. It's disseminated metastasis. It's very important for medulloblastoma to indicate imaging of the whole neural axis. Very good, my friend. Let's see another case for you also. Yeah, this one. Adult patient with headache.
So I've been presented with a non-contrast CT brain of an adult patient presented with headache. The first abnormality I can see is hyperdense lesion centered again in the region of the cerebellum. This is hyperdense, is heterogeneous with predominantly hyperdense areas, and it is causing hydrocephalus with the dilatation of the upstream ventricles. So, yeah. So I would immediately inform the surgical team to
You
decompress the hydrocephalus.
you finalized the emergencies in this case. What are the emergencies in this case?
First is the hydrocephalus.
Good. Second.
And then I would see the foramen magnum. Is there any?
Okay. But
Yes,
more
there is
important.
clouding. The hyperdense area in the
Yes.
third ventricle this is the hemorrhage.
Yes, intraventricular. We have intraventricular extension.
Hemorrhage.
Okay. A few lesions in.
Is this hemorrhage or this is
Yes.
extension of this mass?
No. It's a hemorrhage. This hemorrhage is not
Yes.
choroid plexus. In the third ventricle, this is hemorrhage, and also in the lateral ventricle, this is hemorrhage. And if we concentrate, we may find this is one of the hidden areas in the CT or MRI. Layering. Okay.
Layering of the
Look for layering. Yes.
hemorrhage in the
Okay.
occipital
Hemorrhage and infection. One of the hidden areas is a posterior horn of the lateral ventricle. So this is not just hyperdense mass. It's hemorrhagic mass. Very good, my
Yes.
friend. And post contrast, it caused some heterogeneous enhancement. So it's not a pure hemorrhage. Okay, very good, my friend. So what is your diagnosis and next step? This adult patient?
Because it's like a hemorrhagic mass in the posterior fossa, the first differential can be hemorrhagic metastasis, because that is the most
30
common.
years old, I agree, but
30-year-old.
30 years old, unlikely. In older age
Yes,
group,
for
definitely I will put metastasis. Okay, hemorrhagic metastasis. And the next from where? Okay, tell me from where. If older patient, older age group, and you suspected hemorrhagic metastasis, from where?
The hemorrhagic metastasis can be from renal, from the thyroid, from the myeloma,
and in a
sorry,
female,
melanoma, or
okay,
from the lungs.
If a middle age female, okay, we can also add choriocarcinoma. Very good, my friend. But
Choriocarcinoma,
now
yes.
this is middle age male. Maybe a primary lesion arising in the midline of posterior fossa. Like what? If this
medulla?
lesion is not hemorrhagic, what could be?
It can be medulloblastoma.
Medulloblastoma, exactly in this location in a young patient. Okay, no problem. You remember 1, 2. Here, 2 is medulloblastoma. But 1,
Medulloblastoma and the hemangioblastoma.
no.
Oh,
Hemangioblastoma most
ependymoma.
likely,
All
yes,
right.
ependymoma. Yeah, ependymoma.
Yes.
Ependymoma can be associated with calcification, cystic changes, or bleeding. Okay?
All right. Yes.
Hence, there is a heterogeneity. Hemangioblastoma, usually we find a cystic component, a large cystic component, in order to cease such a bleeding, a large cystic component. Okay? Very good, my friend. Very good. Thank you, Abbas. Thank you. Well done.
Thank you, sir.
Okay.
Thank you.
just to revise this part. Remember, my friends, a midline posterior fossa lesion centered upon the fourth ventricle. Okay, think of the two most common differential diagnosis: medulloblastom. Okay, ask for diffusion weighted images. Look for restricted images. Okay, restricted diffusion. And ependymoma, unlikely in children, but it may happen. Usually in middle age group. Free facilitated diffusion and foraminal extension, and also heterogeneity. In medulloblastoma, it's highly cellular, hyperdense on CT scan with no significant calcification, and on MRI, ISO to low even in the T2, and diffusion restriction. In each of these two differential, look for CSF seedling and ask for imaging of the neural axis. If hydrocephalus, raise the possibility, or not raise the possibility, ask for urgent. Safety point is very important in the exam. If you want to pass the case, whatever your description, mention the safety point. But if you did a very good description and you didn't mention the safety point, it's difficult to pass this case. Okay. Other differential can be in the midline also. In elderly patient, whether hemorrhagic or no, we think in metastasis. Another differential in a young adult also, choroid plexus papilloma, if lobulated, homogeneously enhancing. If non-enhancing, it can be and solid subependymoma. Okay, both this lesion as a lower part of fourth ventricle. Cysts also can be in the differential. Next candidate يا شباب.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. My friend, Dr. Ali,
Yes.
how are you?
I'm fine, thank you.
الحمد لله. Okay, يا boss. This is a neonate projectile vomiting.
Let me request the remote.
You have the remote.
Yes. I have been presented with MRI for a neonate with history of projectile vomiting. I will scroll through the images and then I will come back to my finding. Here I noticed that there is hydrocephalus and
Good.
right-sided VB shunt is noted.
Excellent, excellent. Good. So this is after intervention. Very good. Sequence.
Yes. This sequence is flare sequence.
Are you sure?
Because I can see that the white matter is dark.
Okay. What about in neonates? You expected the
neonate,
white
this is
matter
T1.
to be white?
No,
Yes.
T1. Yes, because the neonate is different than the adult.
Demyelinated yet, not يعني well myelinated. Excellent, excellent, my friend. Very good. Okay.
And I can see that there is dilatation of the both lateral ventricles. There is dilatation of the third ventricle, and I can see that there is heterogeneous signal mass lesion noted occupying the fourth ventricle.
Good.
This mass lesion showed extension into the inferior foramen of Magendie.
Okay.
And I can see that there is enlargement of the fourth ventricle.
Okay.
The
What
mass
about
lesion,
its characteristics?
yeah, the mass lesion appears heterogeneous and showed multiple area of low intensity, which could represent cystic spaces.
Okay.
And I want to see if there is any high
high
intensity.
signal intensity within?
Yes, because I want to see if there is any hemorrhage component. I can see in the posterior right aspect there is areas of increased hyperintensity in this T1, which could
Good.
representing hemorrhagic transformation.
Good.
In my routine practice, I want also to review the other sequence for this patient and also
Okay.
to
I'll
assess
give you the contrast.
in the contrast enhanced images. I can see that there is peripheral enhancing and there is no avid enhancement within the lesion itself.
Good. Some heterogeneous, predominantly
Yes.
marginal or peripheral enhancement. Okay.
My next sequence will be diffusion weighted images to see the restrictive pattern of this mass lesion.
Okay, before I give you other sequences, in this age group, a neonate with midline posterior fossa mass and suspected internal hemorrhage due to high signal intensity on T1. What do you suspect?
First, I will put ependymoma at the top of my differential diagnosis.
In
Second,
this age group, I know ependymoma cause hemorrhage more than medulloblastoma. I agree, but in this age group,
this
in a
group,
neonate, it can be
I will,
congenital tumor.
yes. And in this could be medulloblastoma also.
Yes, I agree. Medulloblastoma can be a congenital tumor, one of the congenital tumors. But is it a characteristic of medulloblastoma? Medulloblastoma
No,
usually hypercellular homogeneous and not
Yes.
hemorrhagic, and homogeneous avid enhancement.
Yes.
Unlikely. The remaining one, okay, T2. What do you see in T2?
In
Is
T2,
it
I can
cystic spaces or what?
Yes, this looks like cystic spaces, and there is area of dark which could represent the previously mentioned hemorrhagic transformation.
Good. Good.
So I am thinking about pielocystic astrocytoma.
Pilocytic astrocytoma, not agree with you. This is predominantly a congenital lesion, okay, and predominantly hemorrhagic. One lesion can do these two items. You know or you don't know?
Rhabdoid tumor?
Yes, okay. Atypical rhabdoid teratoid tumor. Yes, it can present in the midline. I don't know if I put it here. Yes, atypical teratoid rhabdoid tumor can occur in very young child, neonate. It can be a congenital form, okay, present in early intrauterine life, and it's commonly to present with sudden onset of bleeding. Excellent, my friend. So till now, lesions that bleed in this area in a neonate suspect atypical teratoid rhabdoid tumor. If paramidline in the cerebellar hemisphere and large cystic component, okay, I'll agree. Maybe pilocytic astrocytoma, maybe hemangioblastoma, but if a cystic component in older age group, for example, middle age, we suspect ependymoma. Elderly patient with severe headache. What do you see?
I have been presented with a brain CT scan for elderly patient with severe headache. After first scroll, I can see that there is hydrocephalus and there is permeation of the CSF spaces.
Good.
And I can see that there is intraventricular hyperdensity representing interventricular hemorrhage.
Good.
Also, I noticed that there is diffuse hyperdensity noted involving the right cerebellar hemisphere, indicated intraparenchymal hematoma. This appears extending into the fourth ventricle. The fourth ventricles appears compressed, not dilated.
Phased, completely phased. Good.
Completely phased. And this hemorrhage appears extending superiorly into the third ventricle, causing obstructive hydrocephalus.
Very good. And H.
Yes,
all three H present here. Look at the foramen magnum.
Yes, I'm now going down.
The name. This is a spot image.
Yes, there is a crowding of the foramen magnum. It's noting.
Excellent. Okay, remember, my friends, if you see a normal appearing CT scan or a normal appearing MRI, especially in exam setting, one of the hidden areas is the foramen magnum. You should see a fluid CSF around the medulla. If you don't see anything here, it's a tonsillar herniation. If nothing else, crowding of foramen magnum or tonsillar herniation can be carry one malformation. Ask for sagittal MRI and upper part of cervical spine for searings and. Back to our case. So what is your diagnosis here, Dr. Ali?
Yes. So this is a mass lesion in the posterior fossa within
Mass
the
or
right.
hemorrhage?
I didn't see any mass per se, but
So it's my question, is it hemorrhagic mass or hematoma?
it is hematoma rather
Good.
than
Why?
mass. First, I would think about complications such as venous infarction complicated by hemorrhage.
Okay. Anything you want to ask about from history?
If the patient is hypertensive or not.
Excellent. Excellent. Yes. Yes. 25% of the hypertensive bleed occur in the cerebellum. Not all hypertensive bleed occurs in supratentorial. Quarter cases occurring in the cerebellum. And the edema is suggestive of just perilesional. Okay. It's a hemorrhage rather than hemorrhagic
Yes.
mass with expected significant edema and usually associated with some chronic manifestations with exacerbation. Excellent, Dr. Ali. Till now, the lesions that cause hemorrhage according to the age group. If a mass in a neonate, a typical teratoid, older age group in the midline, ependymoma, para-midline can be hemangioblastoma if it's a component, and elderly, either hemorrhagic mass like metastasis or just hemorrhage, parenchymal hemorrhage. Parenchymal hemorrhage can occur in the cerebellum or even in the brain stem. Very good, my friend. One last case. This is a young adult with headache.
I have been presented with the brain MRI T2 sequence for a young adult with history of headache. I will scroll until the last cut. Then I will come back to my observation. The first abnormality I noticed is within the fourth ventricle within the posterior fossa. I can see that there is mass lesion epicenter within the fourth ventricle causing expansion of the fourth ventricle. This mass lesion also showed mass effect on the brain stem and also the right cerebellar peduncle. And I can see that there is increase in the signal intensity within the posterior and right aspect of the brainstem and the right cerebellar peduncle.
Yes. May represent some edema effect rather than extension. It's okay. I'll give you, because of time, I'll give you the contrast.
Yes, the mass lesion showed avid enhancing after giving of the IV contrast.
Good.
Okay. And I can see that there is no other similar lesion noted within the cerebral peduncle or brainstem, or rather within the cerebral area. I can see that there is a prominent of both temporal horns indicating hydrocephalus. And this is emergency, and I will immediately communicate with the neurosurgical doctor. So
how to be sure if this is a hydrocephalus or just prominent ventricle?
I will see if there is any atrophy within the sulci gyri to see if it is correlate with senile brain atrophy, or I can.
No,
I think
middle age.
Middle age.
I say it's normal, and you said it's a hydrocephalus. Hydrocephalus is an emergency. Any sequence that may help us?
Sequence, I don't know about sequence. Maybe T2.
Yes, looking for what in the T2?
Permeation of the CSF.
Yes, CSF permeation. Very good. And of course, other items of like effacement of the sulci and. Actually, this image can help you in definitive diagnosis. Why?
Because in this image, I can see if there is any extension of the mass lesion through Magindi or Loshka.
No extension. What about the outline?
It is well-defined and lobulated.
Good. And the location?
Location within the fourth ventricle.
Lower part, close to the apex. Very good. What is your main diagnosis here, Dr. Ali?
At young age, I'm thinking about the choroid plexus.
Yes, non-CSF secreting or producing choroid plexus babilloma. Very good, Dr. Ali, and I don't think and it's significant hydrocephalus. We can say no convincing hydrocephalus. Okay, if not significant, no convincing hydrocephalus. Another term can be used. Lobulated border, avid homogeneous enhancement. Sometimes we can see also signal void vessels around because it's a hypervascular lesion. Differential diagnosis, it can be ependymoma, but primarily choroid plexus babilloma. Okay, thank you, ya boss. Well done, well done. Okay, next candidate. I will take the control. Just
yes, I will give.
معلش يا دكتور اسماعيل، ممكن سؤال؟
اتفضل يا فندم.
هو الميدولا بلاستوما ينفع تطلع برات يعني فرامل الاكستنشن؟
Yes, it can. ميدالوبلاستوما، طيب انا كنت هقول لك ماشي، no problem. Okay, my friends, medulloblastoma has many types according to the location. The commonest one will be centered upon the fourth ventricle, especially the roof of fourth ventricle as it arises close to the vermis. Other types, according to the location also, it can affect the cerebellar hemisphere itself, not in the midline, paramidline. Or even it can affect the cerebellar peduncle, and with such lesion, it can be extending into the fourth ventricle, into the foramina, and may mimic medulloblastoma. Other uncommon type, nodular thickening of the folia. And this lesion may be difficult to diagnose. I think I will bring you a case. So it's important to ask for diffusion-weighted images. If mimicking other lesions, diffusion, because the restricted diffusion lesions are very few. Okay, my friend. The next candidate.
Assalamu alaikum, sir.
Alaikum assalam wa rahmatullahi wa barakatuh. March candidate?
Yes, I'm March candidate.
Okay, how are you, my friend?
Alhamdulillah.
Okay, middle-aged patient with headache. Dr. Mariam, I think?
Yes.
Okay, boss.
This is axial T2-weighted MRI of a middle-aged patient who has presented with headache. I will scroll through the whole stack of images and then I will start describing. I can see that in the main abnormality in the posterior fossa is lobulated T2 hyperintense signal intensity mass lesion, which is occupying midline, fourth ventricle, with compression of brainstem and cerebellar vermis. It appears to be extending eccentrically towards right foramen of Luschka, and there are some internal septations. There is no upstream obstructive hydrocephalus.
Excellent, pertinent negative. Excellent, pertinent negative. Yes, my friends, all of you should, I'm sorry, my friend, for interruption. We should mention the emergencies, whether positive or negative, should be mentioned. Like our friend said, no supratentorial hydrocephalus. It's very important because the lesion here is centered upon the ventricular system. Okay, yeah, you can continue, boss.
There is crowding at foramen magnum.
Good.
And
crowding here is due to herniation or extension
of the mass, due to extension of the mass lesion at the level of foramen of Magendai, most likely, which I will further confirm. I want to see other sequences like post-contrast and diffusion-weighted images and flare images, if available.
Good. Primarily, you have a lesion of high signal on T2 and extending through the foramina of Luschka on the right side and of Megendi and the middle-aged patient. So what is your suspicion till now?
My first differential will be ependymoma in this case.
Okay. Any other differential?
Other differentials.
Okay. I'll give you contrast. I'll give you... Yes. Huh?
Any cystic posterior fossa neoplasm, although it is centered on the ventricle.
Okay. I'll give you... choroid plexus can be cystic?
No, sir, I was excluding the possibility, but it is cystic epidermoids is usually extraaxial.
Agreed. You said cystic lesion can be differential. Okay. After contrast.
This is axial post-contrast study of the same patient in which I can see that the lesion is not showing any definite enhancement.
Good. So non-enhancing.
Yes.
Good. So most
and
likely
is fluid
represent
signal
what?
intensity.
Good.
So a non-enhancing lesion in posterior fossa can be include different differential possibilities. The location is not typical for an epidermoid cyst. And
what is the commonest location
can be
for epidermoid?
Cerebellopontine angle, extraaxial. It's usually extraaxial in location, and can be cystic variant of some ependymoma, although
no solid. No,
not a typical.
uncommon.
Yes.
Uncommon. Okay.
Uncommon.
Any other
Or
sequence that may help you?
Flare or diffusion.
Excellent, my friend. I will give you here in flare. It's heterogeneous and in diffusion.
So it's epidermoid cyst. The findings are more in favor of epidermoid cyst.
This is actually common case in the exam. Why? It's called typical case or typical finding in atypical location. Typical finding, it's cystic, lobulated, insinuating itself between the structures. Yes, it can extrude through the foramina. Yes, but diffusion restriction. Few lesions that may show diffusion in this area. Midline, posterior fossa lesion. If solid, I'll think in medulloblastoma. If cystic, I'll think in epidermoid. Excellent, my friend. This is a common exam case. Okay, I'll give you another one. Just give me the mouse. Give me the mouse. Okay. Yes, epidermoid can occur anywhere. Okay. Okay. This lesion, okay, this patient, I'm sorry, a child, okay, and assessment of VB shunt for hydrocephalus.
Okay. This is axial CT brain. This was the last cut. It is the last cut.
Yes. Okay.
Of a child who has been reassessed for VP shunt functioning. I can see that there is right-sided VP shunt placed with its tip in the right lateral ventricle.
Good.
Abutting the cavum septum pellucidum at Verdi. And there is no dilatation of lateral ventricle.
Good. After VP shunt, the child showed mild improvement, then recurrence of the symptoms again.
Okay, but I can see that there is dilatation of fourth ventricle.
Excellent.
So in a patient who has dilated fourth ventricle, but non-dilated lateral ventricle, I will focus on in the region of cerebral aqueduct. If there is any stenosis in aqueductal region, which can be a possible differential in this case, that aqueductal stenosis is causing obstructive hydrocephalus.
If aqueductal stenosis, the fourth ventricle should be normal.
Oh, yes.
Okay, upstream obstructed, but downstream normal. Okay.
Yes.
Okay.
Then I will also have a look in the posterior fossa if there is something. It's the last cut.
Good. Till now, it looks like the isolated dilatation. Let's see.
Yes.
It's isolated dilatation of the fourth ventricle. It's not a cystic lesion, but it's a differential diagnosis. With the given history, it's a classic. This is called trapped fourth ventricle.
Trapped fourth ventricle, yes.
Why trapped fourth ventricle? Usually, this type of children presented with hemorrhage, like intracranial hemorrhage, matrix hemorrhage, complicated intraventricular hemorrhage, or infection. Okay, but with the brain substance looks normal, it's sequelae of hemorrhage rather than infection. Okay, preterm, for example. Hemorrhage can lead to arachnoiditis, can lead to adhesion, so it can cause aqueductal stenosis, yes, and also stenosis or adhesions at the outlet foramina of fourth ventricle. Combined together, it can cause trapped fourth ventricle. Okay, so we need here another fenestration for the treatment of a fourth ventricle because it causes manifestations mainly in the posterior fossa. Okay, my friend. So I agree. There is aqueductal stenosis, but again, okay, we have another occlusion downwards, likely at the foramina. Very good, my friend. Very good. So, mashallah, mashallah. Okay, very good case. Okay, thank you, my friend Samsung.
Thank
Okay,
you.
okay. Another case, my
Yes, sir.
friend. Okay, middle-aged
Clear that.
patient with headache.
This is axial T2 weighted MRI of a middle-aged patient who has presented with a headache. I can see that. We'll scroll till the last image. There is dilatation of bilateral lateral ventricles, and fourth ventricle is also dilated.
Good, good.
So it is a case of hydrocephalus and is an emergency, should be urgently conveyed to the neurosurgeon on call. Looking at the posterior fossa in the midline, there is a prominent CSF space, but cerebellar vermis appears intact. So
Good,
its first
good.
differential in this case will be megacisterna magna, or an arachnoid cyst can also be a differential possibility in this
Okay,
area.
I'll hold you just a minute. So we see here, very good, very good. Some cystic dilatation of the posterior fossa, predominantly retrocerebellar. Cerebellar vermis looks fine, okay?
Yes.
At least the superior aspect, okay. And there is a hydrocephalic change, mild hydrocephalic change. Very good. You put megacisterna magna. Megacisterna magna associated with hydrocephalus?
No, it's not
No.
associated.
So
It's
this
a
is
variant.
the least differential diagnosis. Okay, it's
Yes.
not likely. In my routine practice, I will see
I will have
other.
a sagittal sequences also.
Yes,
And
yes, very good, very good, very good. I'll give you sagittal, not just usual sagittal, but usually this will be a heavy T2 and they're taken in 3D before the CSF. What do you
yes.
see?
So this is a heavily T2 weighted image, sagittal image of brain. I just want to scroll through the whole stack. So I can see that there is posterior fossa enlargement.
Good.
I cannot see torcular region, but to have a look on the torcular hierophili inversion.
Good. And we have some cystic dilatation, but predominantly infracellular.
Yes,
The
intracellular
vermis, what
dilatation.
about the vermis? Is it present or no?
Vermis is present because I cannot see
Good.
any direct communication between fourth ventricle and cisterna magna.
Excellent, excellent. So superior vermis and inferior vermis present. So it's not inferior vermian hypoplasia. So we ruled out megacisterna magna, and now we are ruling out inferior vermian hypoplasia, which is previously known as Dandy-Walker variant. Okay.
Dandy-Walker, yes.
Good. And of course, yani, it's not Dandy-Walker malformation. So
yes,
the
it's
remaining
not
one
in favor of Dandy-Walker. Black pouch cyst will be a differential in this case.
Versus arachnoid.
Arachnoid, yes.
But arachnoid cyst usually, let me take
eccentric.
yes, I will take the control just here. Predominantly retrocerebellar rather than infracerebellar, and usually the outlet foramen of fourth ventricle will be normal in case of arachnoid cyst. But here, there is significant widening. Okay.
Yes.
So excellent, my friends. This is a classic plaques pouch cyst. A defect in the formation, defect in fenestration of the outlet foramina. So it's commonly associated with supratentorial hydrocephalic. And due to some obstruction against the CSF here, okay, some layering can be seen and flow artifact, CSF flow artifact. Very good, my friend. So this cystic lesion at the posterior fossa, most likely with this widening, representing plaques pouch cyst. Excellent, excellent, my friend. Excellent. Okay, you took 2 cases? Okay.
Yes, three cases.
3, mashallah, mashallah. Okay, I'll go for the next candidate.
Thank you, sir. Jazakallah.
وإياكم فن. Thank you.
Good evening,
Okay,
sir.
how are you, my friend?
Fine, sir, fine.
Dr. Vishnu, right?
Yes, sir.
Okay, big boss. Okay, ask for control. This is easy case to start with.
Yes, sir. Control is requested, sir.
Okay. middle-age patient with some focal neurological deficit.
Here I am presented with the MRI brain images of a middle-aged patient. I am scrolling cranially to caudally till last cut. There is no evidence of tonsillar herniation is noted. And this is a middle-aged patient. And the most striking abnormality I can see that is centered in the left cerebellum. There is a enlargement of the left cerebellum is there. And with the tigroid pattern is there in the left cerebellum. That is suggestive of Lermitis-Dulcos syndrome, dysplastic cerebellar ganglion.
Yes, yes, very good.
Cerebellar gangliocytoma. Now, I am looking for emergencies in this case. There is no evidence of tonsillar herniation is noted. There is no obvious hydrocephalus is noted, and there is a mild mass effect is noted over the medulla. Apart from this, I want to check the post-contrast images to see any type of the enhancement. And this can be a part of the Cowden syndrome.
Or isolated. Very good, very good, very good.
Yeah.
If this is a male patient, okay, and has testicular abnormality, what do you expect if you're suspecting Cowden syndrome? That was a case from my practice, scrotal ultrasound showing echogenic lesions in both testes, testicular lipomatosis. Testicular lipomatosis. So we did MRI and also ultrasound for the thyroid, the rest of Cowden syndrome. Very good, my friend. So it can be isolated or a part of Cowden syndrome, but it's not responsible for the symptoms. What else?
Yes, sir. Then I am checking for other abnormalities. There is a bilateral periventricular hyperintensities are noted.
Good.
Centered in the periventricular deep white matter and corona radiata and centrum semioval. I want to check the flare images.
Flare and sagittal, not just a flare.
Yes, a flare with sagittal.
Okay. Of course, I will not and talk about this. It's well covered by our big boss.
So there,
okay.
Yeah.
Okay.
There is a
so yes.
There is a oblong, there is a elliptical oval shape and lesions are noted in the periventricular white matter, which are perpendicular to the ventricular surface, and they are Dawson finger. And then I check the especially the quelloceptal surface involvement, and I want to check the other involvement in the cerebellum. There is which I will check on the T2 weighted images.
Axial T2, very good. And also the spine and optic nerve, very good. It's a classic case of MS, but just to look again, I brought it mainly for this one, okay, Lermit-Douglas syndrome. Striated pattern or tigroid pattern of high T2, no significant mass effect, no significant edema. It can be seen in isolation or syndromic, but take care of a distractor. It can be a distractor and the main complaint due to other thing. Okay, my friend, just to revise the differential diagnosis of this pattern. A similar pattern also tigritoid, but the patient has fever. What could be?
That can be the cerebralitis. If the patient presented with the fever, that can be the cerebralitis. If the patient has some weaknesses there, that can be the posterior inferior cerebellar territory infarct.
Excellent. So it's very important to ask for diffusion. Because this is another patient also with some tigritoid pattern, but diffusion restriction following a territory. Which artery?
This is pica, posterior inferior cerebellar artery infarct. Yes.
Excellent. So the tigroid pattern or striated pattern of the cerebellum, it can be related to Lermit-Douglas, cerebralitis, okay, or infarction. Cerebralitis and acute infarction, usually acute presentation. Lermit-Douglas is not. Okay, as final case, this is a child with ataxia. You can scroll.
Yes. Here I am presented with the MRI brain images of a child who presented with the ataxia. I am scrolling from the upside down. Here, my initial observation, I can see there is moderate hydrocephalus is noted, a dilation of bilateral lateral ventricle, third ventricle with periventricular ooze, significant periventricular ooze with a lesion which is centered over the right cerebellum that is causing significant compression of the brainstem and the fourth ventricle, leading to the moderate obstructive hydrocephalus. This is a urgent finding, moderate hydrocephalus. I will immediately pick up my phone and urgently communicate for the hydrocephalus region, and it should be
Also some
relieved by the
herniation.
treatment. And then I will do the rest of the. I want to see the rest of the images to look to further evaluation of this lesion, which is centered on the right cerebellum. There is enlargement of the right cerebellum.
Okay. Post contrast.
Yes. In the post contrast images, there is no. I want to see the plain images with the along with the post contrast images to see any obvious
Just
enhancement.
okay, give me. I'll try. T1. Okay, I'll give. Unfortunately, T1 here is just in the form of a coronal, and my internet is not okay. It's very slow. Okay, my friends, this is a T1 before contrast and T1 post contrast.
Yeah, on the post contrast images, there are thickened cerebellar foci are noted, and with enlargement of the right cerebellum as well, and with the compression of the ventricular system with severe hydrocephalus. So putting it all together in a pediatric patient, this is a congenital condition, Lermite's Dulcos syndrome or dyscerebellar.
Okay, that's Lermite-Douglas cause marked nodular thickening and enhancement. Is this its pattern?
No, sir. It is something
And
different.
Lermite-Douglas can present early as 1 year old?
No, sir.
Unlikely also. So it may be a mimic. Very good, my friend. So we discussed here, if we see this tigroid pattern, it can be Lermite-Douglas, it can be cerebritis, cerebralitis, it can be infarction. This is the final one. If a nodular enhancement and thickening, this is a rare type of medulloblastoma. Yes, age group, cerebellar lesion in the pediatric age group. As I said before, it's uncommon, my friend. Okay, so medulloblastoma can present in the midline, in the cerebellar hemisphere or peduncle, or just thickening, nodular thickening and enhancement of the cerebellar folia. I know it's a difficult case, so I will bring you easy one. Okay. You can start this one, yeah, boss. Hearing loss.
Sir. Hearing loss. Okay. Yeah. Here I am presented with the non-contrast CT scan brain axial sections, brain window. I am scrolling from the last cut, first cut to the last cut. Here, in my most striking abnormality, I can see that there is a heterogeneous cystic lesion is noted at the left CP angle system, which is looking cystic in the consistency, and that is causing compression over the brainstem and compression of the fourth ventricle. However, in the given images, I could not find any significant hydrocephalus there. I want to correlate with any previous imaging available and go with the MRI for further evaluation.
Okay, good. So till now, a cystic lesion at the cerebellopontine angle. Differential diagnosis can be
epidermoid cyst or the arachnoid cyst.
Good.
If
or
the
cystic
lesion
neoplasm or cystic neoplasm, like what?
Cystic neoplasm can be the schwannoma, cystic schwannoma can
yes,
be
here schwannoma, but meningioma unlikely to present cystic. Very good, very good. So I have a 3 differential. Good. The main differential in your mind is epidermoid?
Epidermoid cyst, yes, sir.
Okay,
Epidermoid,
look
because this is
again at the periphery. Look again at the periphery of the lesion. Any emergency? You remember the 3 emergencies? Any hyperdense
any
areas?
hyperdensity there in the periphery of the lesion.
Yes.
Yeah. So that can be the hemorrhage.
Good. Epidermoid cyst can be hemorrhagic? Or arachnoid cyst? None of them.
No.
Let's see the post contrast. Oh.
Yeah. On the post contrast, there is a enhancement is noted within the lesion. Heterogeneous enhancement is noted, and lesion is looking cystic lesion with multiloculated cystic lesion.
Good.
And I can see that the right CP angle cistern is clear, and lesion is also extending into the left CP angle cistern. So I am checking for any other dural based lesion in the rest of the scan as well to rule out a neurofibromatosis type 2.
Excellent.
And
excellent.
so this is left CP angle mass, and the most likely the vestibular schwannoma.
Excellent, my friend. Excellent, my friend. So take care, my friends. From the first look, it's easy. It's a lobulated pattern, predominantly cystic with some heterogeneity and centered upon cerebral triangle. This is epidermoid, okay? But this is atypical for epidermoid, okay? It's a hemorrhagic foci. In my routine practice, also, I will measure these densities to rule out if it is hemorrhage or no. Epidermoid unlikely to cause hemorrhage. Okay, not medulloblastoma. Okay. And in post contrast, it's enhancing in a heterogeneous pattern. Schwannoma can be solid, can be cystic, can be predominantly cystic, multilocular. It's very important to assess. Yes, I see some extension. I'll assess this in the bone window, and I'll advise MRI for also. No similar lesions on the opposite side, because if any small enhancing lesion here, oh, NF2. And also, it's important, any schwannoma in your exam, especially any acoustic schwannoma, you have to assess the upper part of the cord for any expansion by ependymoma, and you have to assess any dural-based lesion in the rest of the study for any meningioma. Okay, because ependymoma meningioma with acoustic schwannoma, again, it's NF2. So this case is important. I think, okay, the remaining candidate. Thank you, Dr. Vishnu. Thank you, my friend.
Thank you, sir. Thank you.
Okay, the final candidate for today because of time. عليكم السلام ورحمة الله وبركاته. How are you, يا boss?
Good, sir.
الحمد لله. Okay, Dr. Amina, I think.
Yeah.
Yes, okay. Can you ask for control?
Yes.
Inshallah, easy case. I'll guide you. Hearing loss.
Okay. This is MRI brain axial. Axial T1 weighted images. I'm scrolling through the images, then I will start commenting on my findings.
Sometimes we may see some high signal intensity in the vessels. It may be artifactual. And other younger colleagues can mistake for this. It's post contrast. It's very easy to assess the main vessels and the area of the nasopharynx. Nasal mucosa and nasopharynx is not enhancing, so it's not enhancing study, non-enhancing study. Okay. Back again to our case, my friend, hearing loss.
In this, I can see that there's a well-defined lesion seen at CP angle.
Right or left?
Both sides. Larger on left side, which is extending into... Yes, I will confirm this on post-contrast and T2 weighted images.
Good. Remember, in the exam, are you sure? It's common. Are you sure? Yes, I'm sure. Or I will
There's
confirm,
also some
as you
crowding
said.
at foramen magnum, not much, but some tonsillar herniation is seen.
Good.
However, no significant hydrocephalus is appreciated. I would like to confirm my findings on post-contrast images.
Very good, my friend. And also, another sequence. Is there any sequence for the nerves?
Yeah, this sequence.
Yes. cyst sequence or Viesta, very accurate because it's taken
in this
also
I
in
can see
3D.
there are bilateral CP angle masses which are extending into internal auditory canal. So
very good.
These are vestibular nerve schwannomas.
Good.
And bilateral vestibular nerve schwannomas are seen in neurofibromatosis 1. I'm highly suspicious for these lesions.
Neurofibromatosis 2.
So 2, yeah.
Okay.
Neurofibromatosis 2. Yeah, so I will look for meningiomas or ependymoma. I will search whole neural axis of this patient, see post-contrast images.
Good. I'll give you
Also family
another
history.
case because of time. Okay. Another case, hearing loss.
Okay. This is CT brain axial non-contrast of a patient who presented with hearing loss. In this, I can see there are multiple hyperdense lesions seen. There is hyperdensity seen in FRCR. Multiple hyperdense extra-axial lesions seen in bilateral cerebellar hemisphere, in cortical
very
region.
Good. Yes.
And parafalcine.
Dural paste,
Left
no problem.
parafalcine.
Good.
Causing mass effect and some vasogenic edema.
So any explanation for the hearing loss? You mentioned all lesions even in the posterior fossa extra-axial.
Yeah. Okay, I'm looking at the CP angles. There is some fullness seen at CP angles.
Excellent. Good. I don't see the usual cerebellum-pontine angle cistern. Okay, CSF here
it's
is
lost.
effaced.
Cerebral-pontine angle cistern is lost.
Very
So
good.
I am suspicious of bilateral CP angle masses with multiple hyperdense lesions, which can be multiple meningiomas with bilateral schwannomas, caustic schwannomas. So I will, on post-contrast images, there is significant enhancement of lesions seen in cerebellum. I would, there also bilateral CP angles are also showing significant enhancement suggestive of bilateral acoustic schwannomas, which are seen
I know
in
we have some
neurofibromatosis 2.
artifact. Excellent. We have some artifact here. Okay. Beam hardening, but still cerebellum-pontine angle enhancing lesion with intracanalicular extension is already seen. Again, it's in F2. Excellent, my friend. Okay. This is a spot diagnosis actually. It's
Okay, there's a cystic lesion seen in left CP angle.
Easy. I'll give you another case. Okay, this is easy. Okay, how to differentiate this from a cystic schwannoma? Absence of hemorrhage is a helpful effect, and the normal diameter of the internal auditory canal. Yet CT without contrast is not enough. I have to proceed with contrast, and or I have to do MRI looking for the classic diffusion restriction, okay, and of course any heterogeneity in the flare. Good. This is the last case, my friend. Headache.
This is MRI brain T2 weighted images. I'm scrolling through the images, then I will start commenting on my finding. This I can see gray white matter differentiation is preserved, ventricular system appear normal, no mass effect, midline shifts seen. Okay, there is a well-defined cystic hyperintense lesion seen at the posterior aspect of cerebellar vermis.
Good.
This is heterogeneously hyperintense on T2.
Good.
There's mild compression effect on cerebellar vermis. However, fourth ventricle and ventricular system appear normal. No mass effect seen on ventricular system. No hydrocephalus. I will see this on post-contrast images and DWI images for further evaluation.
Okay. Post-contrast.
There is no enhancement seen on post-contrast images. I would like to see DWI images.
So till now, my differential will be 1, 2.
Yeah, cystic lesion, arachnoid cyst can be epidermoid cyst.
Very good.
Because there is no enhancement, no eccentric mural enhancing nodule seen.
Yes. So with this location, it's not typical for any cystic lesion. Arachnoid commonly at the middle cranial fossa, epidermoid commonly at cerebellum-pontine angle. It's a cystic lesion, okay? And non-enhancing, but on diffusion, wow.
Yeah, this is epidermoid cyst. I will immediately refer this patient to neurosurgery for resection.
Excellent. So again, epidermoid is a common exam case. Typical finding in atypical location. Okay, just the last item to revise. We revised here middle cranial midline lesions in the posterior fossa, and here cerebral-pontine angle lesions. If we see an enhancing mass, schwannoma on top of the differential, okay? 80% of the enhancing mass at cerebral-pontine angle. Others, meningioma, it will be homogeneous, dural-based, plus or minus dural tail. Trigeminal schwannoma, okay, I will take the control. Okay, just leave it to me. Okay, trigeminal schwannoma, usually arising from the Meckel's cave, so dumbbell shape. In old age, metastasis should be in the differential. High signal T1 in the cerebral-pontine angle, again, it can be hemorrhagic schwannoma. If non-enhancing, it can be white epidermoid, less likely lipoma or dermoid. CSF signal intensity, the next step is diffusion. It can be epidermoid, this is common, or arachnoid. Epidermoid has a lobulated border insinuating between the tissues and restricted diffusion. Okay, thank you, my friends, and thanks for big boss, my senior, Dr. Talat.
Not mine. Ismail, really, we enjoyed your session too much. Really, and for me, I saw many tips, many important points that I didn't see this one before. Really, thank you so much for your well-organized cases. Really. And thank you for your discussion. Thank you for also for the volunteers who shared